Well, I tell you what, I just want to bring in this analogy with Mercedes-Benz. And when my dad asked me what I wanted, the single best thing I wanted in life, and I was a little kid, I said, like a true Indian, the only thing I want, Dad, is a black Mercedes-Benz. And my institution, strangely enough, wrote this very interesting paper. This was one of the most cited papers in 2010. And if you haven't read it, open the BJUI and take a look. And the headline was this: why don't Mercedes-Benz do randomized trials? Fair question. They brought out the next generation SLK. The SLK has been around for 50 years. Each time they bring out a new one, why don't they do a randomized control trial to see which one is better? The reason they do a randomized trial or not is very simple. They believe in a process of statistics which says life is not straight. So today life is here, tomorrow life is there, and day after life is there. So as long as you have a linear progression upwards, it is fine. You don't need to do a randomized control trial. So when we started in 2004 doing robotic cystectomies, the chap who wrote this paper, Tim O'Brien, my good friend and colleague, Alex knows him well, said, forget about a randomized trial, just do robotic assisted radical cystectomies. So that's what we did for a number of years. And Declan Murphy, who was my fellow at the time, published one of these first papers in the Platinum Journal on our initial cases. By this time, I had done a few intracorporeal conduits and neobladders, having spent time in Indy Gill's Cleveland clinic. But then came Indy's the 55% complication rate on laparoscopic radical cystectomies with complete intracorporeal reconstruction. So we said upfront that our reconstruction was going to be extracorporeal. So that's what we have continued to do. And we watch the space that Alex and Khurshid and Peter Wicklund have created with great interest. And I think 2012 is the year when we move to intracorporeal ourselves. The reason why we have struck with extracorporeal is simply because of this. We have a randomized control trial now running, and all three techniques are balanced as far as the reconstruction is concerned. So the reason for telling you this is because we had a 34% complication rate on the first 50 patients that we did robotically. And this was published in urology. And you will notice there are a number of left-sided ureteric strictures. And by this time, of course, Peter Remington, who was my comrade in arms doing laparoscopic radical cystectomy, really pioneered the technique in the United Kingdom, was also getting left-sided ureteric strictures. So we were getting more and more concerned about the 34% complication rate. And if you look at the complication rate beyond 30 days, which is what the Clavian-Dindo classification asks you to do, it is much higher. And I started thinking, if you really look at a cystectomy patient, however done, up to 10 years, then probably 80 or 90% of them will have some form of complication, whether it is stomal, ureteric, cancer control, whatever it might be. So I think it is stupid to think that somehow we don't have very many complications in radical cystectomy, however well we do it. I was much relieved when the International Robotic Cystectomy Consortium happened, and at the time I asked Jim and Khurshid as to whether we could put a randomized control trial within the consortium. That, of course, didn't happen for reasons that are best left alone. By this time, another thing happened. Peter Remington kept saying, well, let's have a look at your open, my laparoscopic, and your robotic data. So the open operations are contemporary. They are done by Shamim Khan, who is a magnificent open surgeon, beautiful hands, little ones. Laparoscopic, all done by Peter Remington, and robotic, all done by myself and my team. And here, I felt pretty good. You will notice that my complication rate had by now dropped to 27%. Peter was about 10% up, 37. And Shamim Khan, of course, like Amit Shab Singh, was reporting a 65% complication rate. So I was winning. The cancer control clearly is simply because robotic had been done for the least amount of time. Notice also that I was taking longer than the other two guys. Peter, by this time, was doing this operation in just under 5 hours. So this is where the scene is set for a randomized trial. And I can tell you this, unlike prostatectomy, where the bird has flown, we tried to set up the LOPRA trial in London, laparoscopic open robotic assisted radical prostatectomy. I can tell you, as of this month, we have had to go to subjecting reporting on the trial. Only 1 in 20 patients agreed to be randomized. And the Cancer Research UK, which funds these trials to $1 million or $1.5 million, the first thing they ask you is, show us that the feasibility of randomization is possible. That is how modern trials are running. You have to show that this is not a comic opera. You can actually randomize patients. So as far as we are concerned, the LOPRA trial is dead. What about the CORAL trial? And CORAL stands for cystectomy, open, robotic, and laparoscopic. And the intention with our statistician was to find a trial that would answer the question which needed to be answered. Because at this time, in 2012, we do not know whether one is more superior than the other. And our statistician promptly came back and said, you need 47 patients in each arm. And this trial started nearly 2 years ago. So this was the initial consort chart on the trial, where Cancer Research UK, as usual, who had funded it, said we want to know whether the randomization is feasible, because on the other side we have already lost. You couldn't randomize successfully into the. So here is the consort showing that 75% of bladder cancer patients who were eligible to be randomized and who agreed to be randomized were part of the CORAL study. So at least here we are, the initial part of the feasibility is fine. So we are winning. Now, as soon as we reached 60 patients, it also became obvious to the statistician that the differences were so large that we didn't need to continue to 147 patients. So the trial, as far as we are concerned, recruited fully till the end of last year, and we presented the initial results at the ERAS in Stockholm. And this is just to fill you in. ORC is open, RALC is robotic, and LC is laparoscopic. You will see that the patients are well matched for age, sex, and ASA status, as well as BMI. When we looked at the initial open series, the BMI was slightly higher, but if you look at it anyway and you confirm for it statistically, there is no difference. The primary outcome measures again show that the greater complications, the more Clavien 3 and Clavien 4 complications seem to happen in the open group. So the short-term measures, and as I said, the trial has just closed, are this. These are the punchlines. 75% of eligible patients agreed to randomization to the CORAL study. Oncologically, the three are equivalent as far as lymph node counts and margin rates are concerned. The blood loss for laparoscopic and robotic are less than open. The operating time for open is less than laparoscopic and robotic. In fact, laparoscopic continues to be less than robotic. And the Clavien complications are the least for robotic and laparoscopic, about 37% versus 62%. So what we saw in the cohort study seems to be reflected in the randomized trial. So for those of you who do not know Peter Remington, let me tell you, he's a tough guy from Cape Town, and he instantly pounced on me, having gotten me drunk, saying, here you are no better than I am. And he was right. We are no better robotically than he is laparoscopic. What he didn't know was, in parallel, there was a quasi-randomized control trial running in my lab, and let me share that with you. So the quasi-randomized control trial is this. Alex turns up in my lab first thing in the morning. He doesn't know at 7 a.m. what he's going to do that day. All he has to do is strip the top bit of his clothes and have fiducial markers stuck to him which are then traced with 7 high-speed cameras. He's also stuck to a machine which is an EMG machine. So this is a rather uncomfortable set of circumstances, and we applied to our IRB to do this real time in the operating room, and they said, no, I'm sorry, this will affect patient care. So you do it in your lab, that's fine, not in the operating room. So there's quite a bit of kit in this gate lab where the surgeon is being tracked, whether he is doing it open surgically, laparoscopic, and robotic. And you keep carrying on doing the same thing for 5, 6, 7, 8 hours till you can't continue anymore. So have a look at the graph right at the bottom. And this is the punchline from this quasi-randomized study. O is open, L is laparoscopic, R is robotic. The higher the value on the y-axis, the more is the fatigue of the surgeon, and the worse is his performance, the longer he or she carries on operating. So you'll find that O and R perform better than L. L has the highest figure of Borg scale on the y-axis. It has the highest confidence intervals. When I showed this the first time a year ago, an open surgeon said, in fact, I think it was Raju Thomas, who's not an open surgeon, but he said this: you have for the first time shown that open surgery is better than robotic and laparoscopic surgery. He completely missed the point. The point of these experiments was to show, possibly, that robotics combine the best open and laparoscopic, the best accuracy, the least fatigue of open, and the best of laparoscopy, which is minimal access. So I said to Peter, you're absolutely right. We certainly do not do a better job robotic, not in a randomized trial, than you do laparoscopic. But here is the difference. At the end of a long day, you go home completely shattered and look for that packet of pantoprazole so that you can treat your stress ulcer. I go home at the end of the day and have a glass of wine. Thank you very much indeed.